We feel like we are casting from the headquarters. It's exciting to be here. I'm called Deborah Jambo. I'm your moderator this afternoon. We want to welcome our panelists and welcome our participants. You know, here at the AfriChild Center, we love beginning with prayer. And I think it will be a good idea to pray. I want to welcome all our participants. Thank you so much for coming. Let's see who's going to lead us in prayer. Would you like to lead us in a prayer, please, as part of our tradition and culture as AfriChild?
Sure. Okay, let's have ourselves for so Lord God, I want to thank you for this great afternoon. Thank you for meeting us together. Deliberate matters that concern the child. We ask of you to be the process and may this engagement be very fruitful. Pray all this in the Lord's name. Amen.
Amen. Thank you so much. We do appreciate that. Again, welcome everybody. We appreciate everybody who has spared time and logged on this afternoon for very, very interesting conversation. You know, I'm excited about children and excited about what we are going to be talking about this afternoon. Just as a way of reminder, this afternoon we are talking about interventions to address stigma and mental health challenges among children and families in low resource settings. That's our focus this afternoon. And I think let's immediately, I want to introduce our speakers, our panelists this afternoon. We are privileged to have amazing panelists with us today. Our major, I would say, presenter this afternoon is Dr. Proskovia Nabunya. Now, one of us, even if she's very far away now, Dr. Proskovia Nabunya is an assistant professor and co-director of the International Center for Child Health and Development. Her global research focuses on HIV prevention, treatment, and stigma reduction interventions, mental health, and family and community-based support systems for children and families in low-resource settings. She has over 20 years research experience conducting research among children, youth, and families impacted by HIV and poverty in sub-Saharan Africa. In addition, she has authored over 100 publications in her field of research. Her work has been primarily funded by the National Institute of Mental Health and the National Institute for Child Health and Human Development. That's huge. And she serves as an expert reviewer on HIV special emphasis panels of the NIH. And Dr. Nabunya has mentored numerous graduates and doctoral level students and trainees, both from the US and from sub-Saharan Africa. Dr. Proskovia, we are glad you're here and thank you for accepting to be our key presenter this afternoon. Welcome, welcome. We thank you that you're here. And then we have another presenter today. I'm telling you, today is a great day. We have amazing presenters. Our other panelist this afternoon, ladies and gentlemen, is Dr. Richard Balikoa. Actually, my colleague, we sit next to each other at Makerere University. Dr. Richard Balikoa is an educational and school psychologist. He lectures at Makerere University with a distinguished career in education, psychology, educational technology, and research. Dr. Balikoa has significantly contributed to research and understanding of community, educational, and child-related psychosocial issues in some sub-Saharan Africa, particularly in Uganda. His work emphasizes supporting the training of educational, violence, school, and gender psychology experts, as well as provision of consultation to families and school personnel on issues related to mental health, learning, and behavior. Dr. Richard, you're welcome. We are glad you accepted to be part of our panelists this afternoon. And nice to have you here. And then our other panelist for the day is Precious. I call her Precious. She's called Grace Obalim. Grace is a mental health expert. She's the mental health and psychosocial advisor at TPO Uganda, a technical role that oversees the MHPSS department. Additionally, Grace is the national coordinator of Uganda National Platform for all mental health stakeholders in Uganda. Wow, what an amazing role, Grace. Globally, Grace is a member of MHPSS East and Southern Africa Group of Practice Steering Committee. Grace, thank you so much for being here, and we are glad you honored the invitation and make time to be part of our panelists this afternoon. We are blessed to have you here. So, ladies and gentlemen, those are our panelists for today, and I'm sure we are going to have an interesting conversation. And right before we dive into our presentations, just a reminder about our house rules. It would be helpful kindly to, mute if you're not speaking or contributing, just to respect everybody and make it easy for all of us to be able to participate. That would be very, very helpful. If you have a question or a comment, you can kindly use the chat. We have an amazing team here at our broadcasting house that is going to help be able to get those messages, chat messages or questions. So we are in very good hands. I'm here with Emma as well. Those of us who've been with AfriChild, it is hard to do this kind of presentation without Emma. When you talk about IT, Emma is always beside us here. So we thank you so much. So I hope we are all settled in and ready to start. I see we have about, how many people, Emma, on call? 52, wonderful, that's great. Really good, thank you everybody for turning up. So now let me invite Dr. Proskovia. I've introduced, I've told you about who she is. Dr. Proskovia, welcome. And would love you kindly to share with us what you've prepared. You have 15 minutes, Proskovia, please, to be able to share with us. Take it away, please, Dr. Proskovia. Welcome.
Thank you. Thank you so much, Dr. Deborah, for the introduction. And I would like to start by acknowledging and appreciating AfriChild Center for inviting me to share my work. And I'll go ahead and share my screen. So just to make sure my camera is still not enabled. So that's okay on your side. So that's the practice. The camera is not on, right? Okay. So I'm going to share my work, which is being conducted in Uganda in the Greater Masaka region. And I'm going to focus on 2 studies where we are testing interventions to address stigma and mental health challenges among children and families in the Greater Masaka region. And the reason really why I'm interested in this work and why it's important is because we cannot address HIV or try to ensure the end of the HIV epidemic without addressing the mental health issues. So as you may know, mental health is a risk factor for HIV transmission, but also individuals who are living with HIV at a higher risk of a non-adherence to treatment, and also dropping out of care. So my focus is at the core of the 2 issues. So for those who are living with HIV to be able to address their mental health outcomes, but also individuals who are at risk of HIV to be able to address these issues such that we end the AIDS pandemic in the next few years. And this aligns with a call from the UNAIDS for us to be able to integrate mental health services within HIV care. So I'm going to dive in because we only have a few minutes, 15 minutes. So this is the global burden around HIV. This information you may know. So globally, around 40 million people are living with HIV, and the majority of those are living in Sub-Saharan Africa. Also, unfortunately, 1.4 million of those are children under the age of 15, which means they were born with the infection. And these are children who are going to live with HIV, a highly stigmatized infection, and they really need our support in order to address issues around their treatment adherence, but also mental health and HIV stigma, which are associated risks. So the second issue is the burden of mental health disorders. So while mental health is part of the, it accounts for 13% of the global burden of disease in this age group, children and adolescents who are living with HIV are at an increased burden of mental health challenges. So this is because as children grow up going through adolescence, they're experiencing physiological and psychological changes just as natural developmentally. But on top of that, we are adding them to, they have this added burden of managing HIV. So that increases their distress. And some of the risk factors, some of the factors that increases this include being female, stigma, with HIV-related stigma, the lack of social support because they're growing up and we expect them to move into adult pediatric, from pediatric to adult care, and also a poor adherence to ART due to poverty. So these are issues, these are risk factors that we want to, we are focusing on, and where we're taking the first step to address in some of our studies. Okay, how do I? Oh, apologies, I need to move this. Stop sharing and share again. All right. So in regards to HIV stigma, we know that HIV stigma is a barrier to all aspects of both the HIV prevention continuum, but also the HIV care continuum. So for one to go on either continuum, we begin with HIV testing. So people, stigma prevents people from testing for HIV because they don't want to know their status, but also they're scared of what would happen. For those who test positive, it prevents them from enrolling in care and also accessing broader sexual and reproductive health services. Also, stigma is associated with adverse physical, emotional, and mental distress, but it also does not stop from just the family from the individual living with HIV. It extends to even the family members who are condemned and stigmatized in similar ways because they did not stop that family member from getting infected. And unfortunately, mental health services and stigma reduction intervention targeting children and adolescents living with HIV are very few. Indeed, one of a recent systematic review done highlighted mental health needs and stigma reduction interventions as the primary priorities that adolescents need to be integrated within their care. So this is the reason that we are my work has focused on these two issues.
Okay.
So
Sorry, Ovia, let me just interrupt you a little bit because we're not seeing your slides. I don't know if others are seeing the slides.
Oh, my apologies.
Okay, just a minute, yeah.
Yeah.
Sorry,
Can you
Ovia.
see them now? Can you see them?
I see formative work and lessons learned now.
Right. So, okay. So my apologies. The other slide didn't see. So moving on to some of the formative work and why the moment I realized that this was an issue. So this was a study conducted among children orphaned by HIV. And one of the barriers for those children who are not necessarily HIV positive, but because they lost children they lost their parents to HIV, their social networks outside of their homes or extended family were very, very limited. And these children were socially isolated. And our findings from that, this study indicated that the stigma attached to being an orphan was a barrier for them to engage outside of their family, which we could think that, you know, we know that it takes a village to take care of a child, but with stigma, even for children who are not HIV positive, it limits their potential to venture out. So the first study in trying to address some of these issues, the study that I called CB for Stigma, we all know CB means hope. This was a pilot study conducted in between 2020 and 2021 to really test the feasibility and acceptability of two group-based interventions that have been implemented elsewhere, including Sub-Saharan Africa, to address issues around mental health stigma, but also around treatment adherence. So the first intervention is group-based behavior therapy, which we know that has been effective in addressing mental health stigma. And the other intervention is a family strengthening intervention focused on families. So the multiple family group, which is a family strengthening intervention, has core components, focuses on family rules, responsibilities, relationships, respectful communication, stress, and social support. So within the family. And for this intervention, we bring together families of children who are living with HIV to share about challenges, but also coping strategies, and be able to build that support to address issues around stigma and mental health. And the group cognitive behavior therapy, this is evidence-based. Only youth attended that to be able to address issues around psychoeducation, cognitive restructuring, because we know living with HIV, but also stigma impacts or distorts the children's thinking, but also their ability to cope. So this was done across 8 healthcare clinics within Masaka. So these are some of the topics for each intervention component, and also we used visuals within these curriculum-based manuals to be able to deliver the interventions. Some of the findings, baseline findings from this study, prior to the intervention, we found that HIV shame was prevalent among this population. And these are children between 10 to 14, so they're young, but they're ashamed of living with the disease. And it was shame and non-stigma that was associated with their mental health functioning, including depressive symptoms, hopelessness, PTSD symptoms, loneliness, and self-concept. But we also find that being a caregiver to a child who is living with HIV was associated with stigma by association. So just because the child is living with HIV, and also parenting stress and mental distress. So this is prior to intervening. So we intervened over 3 months period where participants attended those sessions. So in terms of feasibility, we found that the interventions was highly feasible and acceptable by children, but also their caregivers. This was exhibited in the retention rates we had across groups, the attendance sessions, and I should mention that this study was conducted during the COVID lockdown, but we are able to recruit the number of participants we needed, and they also attended the sessions and also rated them highly acceptable, and as you can see on the client satisfaction questionnaire at the end of the intervention, where they rated the services they received and how effective the program was in dealing with HIV-related stigma. And in terms of the impact of the two participating on the intervention on adults and stigma mental health outcomes, we found that the two interventions uniquely impacted the different mechanisms of HIV stigma. So those who participated in the family strengthening interventions reported lower levels of internalized stigma and depressive symptoms. And those who participated in the group CBT reported lower levels of anticipated stigma and also improvement in self-concept. So this is important because stigma impacts individual in via different mechanisms. So it can be internalized or anticipated or enacted. So these interventions uniquely impacted those HIV stigma mechanisms. And in terms of treatment adherence, we saw that both interventions enhanced treatment adherence, both group CBT and multiple family group, as compared to participants who enrolled, who were randomized to the usual care. And even for caregivers, we found that the intervention lowered their depressive symptoms and parenting distress, but also reduced stigma and discrimination attitudes over time. Now, So what did we learn from that particular study? So these findings underscore the importance of bringing children and families together. So usually when we do interventions, we are either targeting children or we are targeting caregivers. But in this setting, we brought multiple families with children in the same group to be able to talk about these issues. And also, so they give families a chance to talk about experiences and share coping strategies which are beneficial, because then it reduces that social isolation and families can share strategies. Also, the other lesson we learned is around task shifting, because for these interventions, given that we do not have trained professionals and not everybody can afford them, we use lay counselors, so community health care workers and counselors within health clinics. We trained them to be able to deliver these interventions, and were acceptable and feasible. And also the last part is this, for future research, we need to develop strategies to address the shame of living with HIV. So these are children who are between 10 to 14. They did not engage in sexual behaviors, so they were born with the disease, but they're living with the shame. How do we begin to address those issues within this young age group? So that's the first study. And the second study is targets mental health, still among children who are living with HIV. So as I mentioned, cognitive behavior therapy is effective in addressing depression, and it has been used in different settings, but it's not scaled up in low-resource settings, including in our country, Uganda. But there is also the use of mobile technology, given that many people now have access to phones. Scientists and researchers have used mobile technology to be able to deliver different health interventions, including within HIV. So the gap is, why don't we leverage the mobile health to be able to intervene and address some of these mental health issues, since they're a barrier to treatment adherence, but also achieving those HIV-related needs. So given the many barriers as well as the lack of trained providers, so using an app may be a viable option for treating depression in this very vulnerable population. So with that, we conducted a study, this is still ongoing, to develop a mobile health app for use among youth, adolescents living with HIV. These are between 14 to 17, taking into account their unique context, culture, and developmental needs. So this is a two-phase study. The first 2 years are really for developing the technology, and then the last 3 years are conducting a clinical trial to see whether the technology has any impact, or the use of the technology has impact on children and youth mental health. So the first phase of the study was completed earlier this year, where we did focus groups. We conducted focus groups with youth and healthcare providers on issues around what would be interesting for them in an app, what would they would like to see, what kind of component, how would that look like, and how they would like that to be delivered. So they gave us feedback on what they wanted videos and cartoons, and we took that information and we integrated that within an app, which is on, they can download on a smartphone. This is a Subi mHealth app. So these are some of the screenshots that you can see, and they are already translated in Luganda. So they can review, we have the educational component where they can review the different aspects of depression, anxiety, coping skills, but these are not just content. They're videos, like 2 to 3 minute videos that they can review every day for about 2 months, but they can go back and forth. So this intervention also has a goal setting where they set whether they want to continue taking their medicine, doing a pleasant activity, doing something related to school or at home, or engaging with their peers. It also have a self-monitoring component where we check in to see whether they took their medication that day or not, and checking their mood every day on a scale of 1 to 5. And also it has emergency contact. So in case something is happening, they can call someone, and these are individuals based at the Masaka Regional Referral Hospital. So they engaged with the app for 2 months. And so from a small scale, so this was tested on a small scale of 30 youth. We found that all of them engaged with the app, 27 of them, the 3 participants were in boarding school and were unable to use the phone. So at 80% reviewed at least one module under each course. They really liked its usefulness and ease of use and the likability. And also we conducted in-depth interviews where they discussed what was helpful, what are the barriers and suggestions for improvement. So that was phase 1, which was completed. And we are now just starting phase 2, where we are going to pilot test this app. So we will incorporate some of the feedback, but then pilot test this app among 200 youth, where 100 of them will get the phone with the app early alone and then engage with the app. And then after those 2 months, those who are randomized to the control arm, which we call the waitlist control, will also receive the app, because we want all the children to benefit from this. So this phase of the study is just beginning, and I look forward to sharing some of these findings maybe in a year or 2 when we have completed this phase. But we are very we indeed think that this will be something that will be potentially effective in addressing issues around depression among this vulnerable group, given that also youth and children have access to phones now, which was not the case 10 years ago. So we are excited to leverage these phones to be able to intervene with the participants. Okay, and finally, this is the wonderful team that helps to conduct these studies, our Uganda-based team, but also the US-based team. And these are our funding, research, and implementing partners. And that's it. Thank you so much. I'll be more than happy to answer any questions. Thank you.
Wow, thank you so much, Dr. Proskovia. That's amazing, interesting work being done. And I think a lot of insights about what can be done to help our adolescents and children in this country and across Africa. We do appreciate that. Thank you, thank you. Please, if you have a question, just take note of it. There'll be an opportunity to be able to respond to questions. You'll be able to put up your hand, but meanwhile, you can take note of it or even post it in the chat. We'll have that opportunity. I see a lot of thank yous coming up through the screen. Thank you, everybody. Now we are going to have some discussions. We shall have questions later on, please, participants. We are going to have some discussions here by our panelists. And let me first invite Grace. Grace, please, like I mentioned earlier, Grace works with TPO, so she's going to share TPO's experience and best practices. Over to you, Grace. Take it away.
Thank you. Thank you. Thank you very much, moderator. Thank you very much to Dr. Proskovia. It was very lovely listening to you. I felt like the presentation should keep running and not stop. Such an amazing work and findings of what you're doing in Masaka. It's such amazing. It's going to help and contribute a lot towards implementation, but strengthen also the capacity gaps and the issues in terms of statistics and intervention that can address HIV among children and family, knowing that the disease burden of HIV is one of the biggest factors that affects treatment and retention on treatment. But thank you very much, Dr. Proskovia. I sat here and I felt like you shouldn't stop. Moderator, kindly confirm for me if you're able to see my screen.
Yes, please. We can see your screen. Wonderful. It's very clear now, Grace. Thank you so much.
Thank you. Thank you very much. So thank you. I want to start by appreciating all the participants who have taken time to attend this webinar. Much appreciation to Afro Child Fund for organizing this great learning opportunity. Like the moderator said, my name is Grace Obalim. I am a clinical psychologist by training, and a practicing mental health expert. I work with TPO Uganda, that is Transcultural Psychosocial Organization, where I work as their mental health and psychosocial support advisor, an integrated technical role that I hold within the organization in guiding and supporting in all our MHPSS. MHPSS is mental health and psychosocial support implementation. I'm going to briefly take us through, building onto what Dr. Proskovia has said. I'm just going to take us through best practice, sharing experience from the implementation of TPO Uganda. Now, TPO, we are a national non-governmental organization that has been delivering services to vulnerable communities in Uganda since 1994. This year, the whole of this year, we have been into series of celebration and reflection of how 30 years of existence has been for TPO. So colleagues, we have made 30 years of providing services to communities in Uganda and out of Uganda. So it's such a milestone. So whenever I speak about this, I bring such a huge smile on my face. And in the 30 years, our commitment has been to restore hope and transform lives of vulnerable community. We are currently in 45 districts across all the regions of Uganda with regional-based coordination offices, and our headquarters is in Kampala at Munyonyo. Our mission is a society, we want to see a society where every individual enjoys mental health and socioeconomic well-being, because we believe general health and normal well-being starts with mental health. And our mission is to empower community, improve their mental health and socioeconomic well-being. We believe that an empowered community is a community that is able to take care of their issues, foster the resilience, and work towards their well-being. We have mental health and psychosocial support is our main niche and our main area of intervention. But we also have other thematic areas where we do implement. We do a lot of implementation on HIV and AIDS, which is largely in Western Uganda. We also do orphans and vulnerable children. We are also into disaster and risk mitigation. We also do implementation around GBV mitigations and awareness raising. But largely, like I said, we are hugely known for mental health and psychosocial support. What is the intervention model that TPO uses? We use community-based approach. We do not do institutional implementation. TPO, I normally tell people in the basic term is that we carry Butavika National Referral Hospital and take it to the community. So we implement within the community structures through the family-based care system and using the community-based structures with task-shifting teams. So all our activities are conducted from within the community, from awareness raising to structured psychoeducation to assessment on the different mental health disorders and psychological challenges to diagnosis and management on both level of medication, that is psychotropic drugs, and the different psychotherapies. We have a number of psychotherapy that we deploy for our implementation and work. Now, looking at the 30 years of implementation and what our experience has been in terms of looking at stigma, addressing stigma around children and families, what have we been able to look at as TPO Uganda? What are some of the interventions that has worked for us that we find has been able to help in addressing stigma? One of them is school-based intervention. When dealing with children, largely the lifespan of children are around school. So over time, we came up with a school-based intervention that are structured within the school system and the school schedules and school times. So we are able to meet and reach these children from within their school structures so that we are dealing with the stigma that is associated to when a child presents with any psychological issue. This school-based intervention covers for both children and teachers. So what we do, we also build the capacity of teachers on how to understand children's psychological needs and be able to support them. But most importantly, instead of focusing at punishment, instead of focusing at sending them home for suspension, maybe look at the different psychological needs that they could be presenting. So we have the school-based intervention. We also do a lot of family-level care. We provide support within the family setting. We go to homes and give support to the children and their caregivers within their homes. We believe that for you to support a child, you need to address their environment, you need to address their social needs, you need to address their spiritual, which is under the ecological model. So we try to look not just at a child as an individual, but we look at them comprehensively and holistically. And we do this within the family care level. We don't take them away from their community. And then we use a lot of community structures. There's a lot of wealth out there in the community. There's quite a lot that a partner can build on. So we pick on the existing structures like the community-based counselors, the village health team, the local leaders structures that are within the community. We build their capacity on basic information sharing and identification of family and children's psychological needs, and use them as our first doorstep people to be able to identify and make recommendations. We also do largely on awareness raising. Awareness raising, we tie it together to information, education, and communication materials. These are IEC that are age appropriate, gender appropriate, and culturally sensitive, translated in different local languages and even the pictures or the information, age appropriate. There are photos that a child can interpret and understand, and there are those that an adult can look at. So we do largely on this that is tied to our awareness raising to ensure that the information reaches out there. And this has helped us a lot in terms of addressing stigma that is associated to mental health. Age and gender appropriate information. There's some information that you can give an adult that a child will not be able to comprehend. So we have different respective interventions. There are those interventions that are strictly for only children. And then we also have interventions that are strictly for adults. But we also have intervention that covers children and caregivers, that is their family. So we do a lot of appropriate information sharing. And then positive information. When we need to deal with stigma, we need to be able to address the myth and misconceptions that comes around it. HIV is one of the sicknesses that comes with heavy disease burden, stigma, finger pointing, isolation, and blame. So even it's close to mental health, not many people know mental health. It was until when COVID struck the world, mental health was a very isolated case that used to attract high level of stigma and misconception. So positive information, these are information that are directed towards giving facts and stating clearly the real issues, what are out there, and making reference to what someone can even go and validate and be able to get the right information that they need. So we do a lot of that. And then finally, capacity building. You cannot be able to support children and family and be able to address stigma among children and family if you leave out the different stakeholders that are responsible. So we do a lot of capacity building of the different respective stakeholders to understand the psychological needs of children and family and how those can be included into their different respective programming, but also how they can be able to facilitate and support the different community-based sharings that can help facilitate a positive environment where children can thrive and live positively with their family. So colleagues and participants on the call, this is briefly what I would like to add on to the wonderful work that Dr. Proskovia has shared with us, and just to bring a little practical perspective on from what TPO has been able to do over time. So thank you very much, and over to you, moderator. Thank you.
Wow, wow, wow. Thank you so much, Grace. It's exciting what TPO has been able to do and is still doing in our country. We definitely appreciate. And thank you for that interesting presentation. Oh, it's a packed day. I see a lot of people saying thank you, the presenters. We've had a rich experience so far. And now let's, please, any questions, any comments, you can put them in the chat. I know some people are already writing questions down and comments. We'll have some time to be able to give you an opportunity to respond to that. But now let me invite our other panelists this afternoon, Dr. Richard Balikowa. Please, Richard, take it away. Welcome. Like I mentioned earlier on, Dr. Richard is an educational psychologist at Makerere University. Welcome, Richard. Thank you.
Thank you so much, moderator, and my senior colleague, Dr. Deborah, and then my earlier friends, Dr. Nabunya and Miss Grace. It has been a wonderful talk on our topic today. And I want to appreciate Africhild for thinking about this specific topic of discussion. This is very, very timely. And I think it is a beautiful conversation that is going on. Now, interventions to address stigma and mental health challenges among children and families in low resource settings. We get a very good presentation from Dr. Nabunya and colleagues. And this specific presentation comes with a focus on HIV as one of the greatest stigma challenges, that causes of stigma challenges, especially among children, and a very big threat to their mental health. We want to congratulate you. I want to join the others to congratulate you, Dr. Nabunya. And then also we get a very wonderful touch of intervention by TPO from Grace. I think these two talks provide a good background for us. And today I will speak generally to the colleagues have already put across. We need to understand, first of all, the low resource settings, and bringing it to the layman's understanding. For as long as a setting has difficulties in access of the basic infrastructure, then that is usually termed by the WHO as low resource environment, low resource setting. The healthcare system, the school system, and other such very basic infrastructure that would have eased the survival of a child as a developing human being. And these environments are usually characterized by financial constraints, by suboptimal healthcare service delivery, by underdeveloped infrastructure, the road network system. When it comes to the area of access to information, it comes to the area of access to the very basic, and safe needs that a human being would have used to survive are really limited. And if they are not to the best standards that would make a child grow in such a safe environment. So it is important to pick on from that. And then this now comes with the challenges. Dr. Nabunya has just presented to us HIV, and specifically from one of the parts in Uganda, and that is the Greater Massacre, that she comes with HIV, which has had history of devastation when it trickled to even children, and that means it's crossing over to generations. And this is, in a way, raising an issue of a cross-generational trauma where generations of children has gone on to spread to even generations up to now, that has even resulted in too many things. We've had lamentations all over. Some of us who are familiar to Ugandan literature, we've had artists like Wilson Bugembe, who tries to lament about the childhood while he's growing up, and how he grows up in an environment where he knows that he lost all his parents, he lost his siblings, including those that followed him. So he was sure he had been born HIV positive. And in a way, there are so many. Now this one is lucky that later he makes it, and maybe out of resilience and other such mechanisms, he's able to make it, and then he's speaking to the world. How about the rest of those children who do not have the platform to come up and speak? It is such a challenge that is so detrimental to their mental health. And have we ever imagined some of the children that has born to parents who are HIV positive themselves or have suffered such, even if they themselves are not positive? They are growing up in unique environments. And most of these low resource environments are known to have their characteristics. They are communal, we are lucky that Grace talks about the community-based interventions, now looking at communities. Without the intervention and the coming up of community generally, then that means such a child will be left in total anguish, and that is detrimental to their mental health. Most of these communities are having given the infrastructure, the kind of infrastructure they have, like the school system. The school system is in a way communal in nature, referring to the studies that we carried out, one during COVID-19 and on children, and another immediately after the pandemic, where in the latter, we're trying to investigate how these children are living during COVID-19, especially the school children. And then the other one comes up to respond to the cries of the pregnancies, the teenage pregnancies that happened during COVID-19. And in both studies, it is interesting to learn of stories from children when they tell us that actually their predicament does not come with COVID-19 per se, but COVID just provides environment to highlight these problems. Many of the teenage mothers confessed the fact that actually by COVID-19, many of them had been nurses. COVID's advent only helps us to know that actually such challenges are happening in these environments. So there are a number of issues that can lead to the mental health and its related effects like stigma for these children, or that these children are going through. And these are not limited to HIV, just like disabilities. Children with disabilities are often stigmatized and excluded from social and educational opportunities. Although Uganda has moved in a way of making this awareness, we cannot be confident to say that we have reached where we should have. Quite a number of people at community level are not well aware that actually when children are growing up and they have any form of physical disability, do suffer. Then the mental health. It is not common here. In most of these environments, many of them known to be in low resource countries, we can say, but still even within the low resource countries, we know well that there are those other unique environments. Talk of the urban environments like the urban slums, talk of the urban slums in many of the places that we know in these countries. We have even some of the slums rightly gazetted, like in South Africa. We have some countries where you may not be able to tell whether it's a slum or not, but trust me, the slum traits and environments and challenges are there. South Africa at least has been known, and interventions have been known also to go there. But we have countries like is a slum and which one is not. And how about the population that are living in such environments? Then we have the remote environments, and the word remote referring to the limited access. To so many one would have think that this is an obvious. I may not mention, but you know many of these regions. So it is important for us to note that when it comes to stigma, HIV being them and as a public health challenge, we have, as I've mentioned, disability, the mental health. The mental health conditions are heavily stigmatized in many cultures, which we have to remember, especially in the low resource settings. Children who experience mental health challenges may be labeled as crazy, possessed, and we've had, some parents discarding these children, and we have a challenge in some of these countries. In Uganda, for example, we do not have a law that protects the people they refer to as imbeciles. We do not have a clear law. So even when a child with a mental health challenge gets a problem in a community, it is easier for someone to ask, is there a dead body? Yes. Oh, who is he? Ah, no. This one is the other, disabled child, the mad person, the mad child. Then poverty, then illnesses, And you know, even if illness would not have been a big problem, for as long as it's a low-resourced environment, it is very, very common to find such children suffering. So it is important as we are thinking through, and then having this conversation about interventions for children from low-resourced environment. Remember that such interventions, like rightly presented by Dr. Nabunya, have to be context-based. And happy that TPO talks of the school-based interventions. And as you have been informed from my practice as a school psychologist for a few years, I come to understand that if schools are prioritized, then most of the challenges that children go through will be in a that later go back to these communities, and again later who become adults of fell humans. Then those family-based interventions will come in. Then the case studies and the other best practices as shared by TPO can also come in, because then we shall have information. We shall have the children as the starting point, and then these children will be as niches, as in paths to make us reach their families and the rest of the communities. So it is really very, very intriguing to have a discussion on a rather important aspect. I end my submission by encouraging us to understand the context of stigma and mental health challenges, and then to understand the effective interventions to address these, some of which I have just highlighted, and then very important that those two will lead us to the case studies, and then the best practices will definitely come in to make a contribution to such. I want to thank you so much, moderator, as I hand over to you. And then, like colleagues, I will be willing to and waiting for comments and feedback from the rest of the participants on the call. Thank you.
Thank you so much, Richard. Another amazing presentation giving us the context of what has been happening regarding mental health, and you have done an amazing job responding as well to what Dr. Proskovia and Grace shared. Thank you so much, Richard. Amazing job. We now come to the time, participants you've been waiting for. You have a question, you have a comment. I see a lot of thank yous in the chat. However, we don't have too much time, so we would love to invite you to quickly post your question. You can put your question in the chat. That is very helpful, or just the question and answer, and then we can respond to that. There's already a question I see here in the chat from Jacqueline. Thank you, Dr. Proskovia. Were the adolescents under the second intervention assessed for depression?
Yes.
Yes, please. You want to respond to that, please?
Yes, I can go ahead and respond. Thank you, Jacqueline, for your question. So yes, to participate, we use the PAQ-9 to screen for depressive symptoms. So, and we took those who scored from mild and up. Originally, we had wanted to take those who scored severe, but again, because of issues of stigma, on why you take somebody who scores 10 and the other one who scores 5, we decided to take those who score anywhere from mild to severe symptoms. And that's what we used in phase 1, and that's what we are going to use also in the second phase of the trial.
All right, thank you so much, Proskovia, for that response. There's another question from Ashraf here to Grace, and he says, thank you so much, Grace. I had a question regarding the different psychotherapies applied. Are they being implemented by mental health professionals or lay counselors? I'm asking because in the case where there are minimal available mental health service providers, we are always looking for evidence-based approaches that can be implemented by lay professionals in low resource settings, especially in low-income countries. Okay, thank you. Grace, would you like to kindly respond to that?
Yeah, sure. Thank you. Thank you so much, Ashraf, for that question. Yes, our community-based intervention, like I said earlier, that we do task shifting. Task shifting means that we train non-specialized mental health professionals to implement and provide mental health services to the persons in need. So the biggest number of our implementers are non-professionals. So what we do is that we have a number of psychotherapists that we do. We have a laid down cognitive behavior therapy for trauma that we implement in a group structure, and it's purely implemented by social workers. We at least recruit social workers with background in social work and community psychology, and then we build their capacity in understanding the basic understanding of mental health, and they implement the intervention in a group setting within the community in the basic way possible that can be able to support. So yes, our biggest respondents are task shift team, non-mental health professionals. However, we have a structure that attaches every non-professional implementer to a technical person. So we have a huge number of clinical psychologists and psychiatric clinical officers on our payroll. Actually, right now, I think TPO is the biggest employer of clinical psychologists and psychiatric clinical officers in East and Southern Africa, because we have a team of over 48 technical mental health persons on our payroll. So they are tasked with the responsibility of providing supervision, but the direct community implementation are done by the non-professionals whose capacity are built on those specific interventions and psychotherapies. Thank you. I don't know, moderator, there are about 2 questions if you want me to answer, or I can wait and pick back. I'm seeing one question. I'm seeing
Okay,
one.
you want to answer the next one as well? Yeah, thank you. I'm glad that you've already seen that, Grace. Go ahead, please.
Yeah, I'm seeing a question, a concern around limited diagnosis of mental health conditions in health center facilities within the country, and due to lack of skills, which is very true. With our experience of implementation in the past 30 years, our biggest resource in terms of capacity building, we have tried to channel it into building the capacity of general healthcare workers on what we call mental health gap. MH gap is an intervention tool that provides a non-mental health technical specialist to know how to do assessment, diagnosis, and management, comprehensive, both for dispensing drugs and then also providing psychotherapy. So it's true, the capacity gap is low, and there's a lot that needs to be done. The capacity building needs to be done. Government has given a structure that mental health is to be implemented within the primary health care, but the technical expertise is not there. So what does TPO do is that we try to train the general healthcare workers so that they can be able to provide that. The next question is saying, is there a best practice program for youth and mental health, for youth and mental health that one organization can reciprocate? Sure, there's quite a lot of learning. I normally speak and say Uganda has a unique setting. We enjoy very close collaborations and coordination among the different stakeholders, right from donors to implementers and learning institutions. So if you look around, for example, under the Uganda National Mental Health Working Group, partners come on a monthly basis and share a lot of best practices and programs. And there are quite a number of youth-focused programs that are out there that are being implemented at various levels by partners that, when properly documented, it can be easily duplicated, or you can easily pick it up and share and be able to implement elsewhere. So there's quite a number of practice. Maybe what we need to improve on is documentations. We need to support partners, support the different people implementing to document some of these programs and interventions. And that's why I'm very grateful to Dr. Proskovia for such a presentation that she has done today. I think those are the 2 questions I wanted to respond to. Over to you, moderator.
Thank you so much, Grace. Thank you for the work you're doing. I think you're missing the counseling psychologists. They'll do an amazing job for TPO as well. Yeah, thank you. Dr. Proskovia, there are some questions here. Juliet is saying, very good presentation. Thank you. And a question for you, Dr. Proskovia. Let's see, I hope I don't miss it here.
Yes, I see both of them, and I would like to respond.
Thank you.
So the first question around the study design, whether this is a crossover RCT, no, it's not. So it's because it's one intervention. So we will do a trial, will randomize participants to the intervention condition and the waitlist control. So the active intervention will have the phone for the app, will engage with the app for about two months. And then once that part is done, we will give the waitlist control the app as well, but we will collect the data at the end point from both groups. So it's not a crossover RCT. Then the other question is from Paul around using Lake Parsons is a great idea. How can one ensure sustainability? So also this relates to what Ms. Gritza just said. So we are using community health care workers and counselors within the clinics to be able to deliver the intervention. So our group CBT was delivered by counselors within the clinics, and our multiple family group intervention was delivered by trained community health care workers and parent peers. So we had trained them to deliver a similar intervention in a school-based intervention, and we utilized them to also deliver the intervention in a clinic-based setting. So the skills they are learning just from learning about these interventions, they're going to use those even after the study ends. So we've had testimonies and where they're actually using them even without the study. Also, we work with the Masaka Catholic Diocese, and they are taking on the family strengthening intervention within the diocese. So they're using it as part of the the parish programs where the families are encouraged to use the multiple family group just to promote those social support systems within the families, and for the well-being of children, but also for all individuals involved. So in terms of sustainability, this is actually it's going on by itself, because we train, and whoever we are training, they're implementing the studies within their communities, even without our intervening with them. I think that those are the only two questions.
All right, there's another question from Scovia. Scovia is saying she'd love to volunteer in any of these activities. How do I get there? Would be nice practicing what I have had. So Grace and Dr. Scovia is ready to be deployed.
Okay, so I would say we have a field office. We have a field office in Masaka, and my colleagues are on here. But I would encourage you to reach out. We have a website, the International Center for Child Health and Development. The contacts are there. So our field office is in Masaka, and you can always get that information and reach out. Oh, and also AfriChild. So they have contacts for our offices.
All right, thank you so much. Grace, Scovia is ready to be deployed.
Yes, thank you. Thank you very much, Scovia. You're welcome. At TPO, we do a lot of internship. That is, it can either be academic-based internship or volunteering to learn and get introduction into the work field, or even come and just do internship to be able to practice what you've been able to learn. So you are most welcome. Like I said, our head office is in Munyonyo. Although I need to warn you that our internship, we deploy you to the community. So you will be sent to one of the different 45 districts. So it's not per se being at Kampala here, but you have to go because we believe you have to learn from the implementation in the community. So you're very much welcome. You can reach out to us through our website, or you can drop in your application for internship, and we'll definitely be able to reach out to you. Or you can reach out to the AfroChild team. They have my contacts, my details. I am the advisor for the organization, and we can always see how to help you grow in your field. Thank you.
Thank you, Grace. I'm sure you'll enjoy Scovia. Amazing students. Okay, Richard, there's a question for you from Andrew. Are you able to see that question, Richard, in the question section? Richard?
come again. Are you able to read it for me?
Let me read it for you, okay? So this is Andrew, and he's addressed it, I think, to Richard. He says, due to early exposure to violence and financial frustrations in the low-income resource settings, children tend to grow up and make decisions way above their age to leave family and go to the streets, as well as carving in without focus and interest due to hopelessness. This prevents children from participating and opening up. So how
Yes,
can...
I think it's not.
So how can social support, well, reach such children at an institution level like schools and families? And he says to Dr. Richard. So please, Richard.
Thank you, Andrew. I've been scanning through to see that specific message, but
He's wondering how the children who are living somewhere, sometimes on the streets and outside their families, can be reached with psychosocial support.
And Andrew, this is why we saw TPO Uganda talking about the community-based interventions as practitioners. So as researchers like Dr. Nabunya and myself bring this data to table, and then the research policy people like now the AfriChild come up to bring this data to the public. Practitioners that bring in the intervention usually have a chance to identify that as a community. Remember, when we talk of community-based interventions, there are different communities. One of them are children who live on street, but also children who live on street. If you go into studies that deal with street children, will tell you that they are classifying them in different communities as well. There are those who are on street because they are homeless. There are those who are on street because they have suffered mental challenges, either during their childhood, or some of them on street due to adversities, talk of calamities. We've had refugee issues, we've had natural disasters happening in different parts of the world, and such calamities usually lead such children to go to street. If you go to the northern part of Uganda, people that have carried out studies in this environment have established that some of the children we see on street that came from there are either children to former children who are running away from the war-ravaged environments in the northern part of Uganda, and then they have lived homeless, and then they have given birth to children who are living on street, and then they adapt and adopt the street life. So when we say community-based, a school is one of them, but unfortunately, some of these ones may not be in school. And so it is for whoever is offering the service to establish, and just like I had said in my presentation earlier on, it is environments, and then we approach them the way I called the context-based. But also finally, I have to remind all participants on the call that in social cultural psychology, we take a note of the different challenges as per the different environments. And as we come in to provide whatever kind of intervention, we are careful not again to cause trauma, because some of these people have been raised in a given social cultural environment, and some of the terminologies that we are coming with to think we are giving intervention are actually just showing us as people who are carrying on with advocacy per se. So I think that's a very wonderful submission, Andrew, and then friends. I want to thank you so much for being part of this conversation. Thank you.
Yeah, thank you so much, Richard, for your response. Colleagues, Grace and Proskovia, there are two other questions. Emmanuel is asking, how can social support maybe reach to children who are victims of HIV/AIDS, parental rape, trauma, and child-headed families?
So thank you so much for those questions. So for that question, so for me, the work I do is focused on those children who are living, who are either living with HIV or orphaned by HIV. but are still living within a family unit. So either with a surviving parent or extended family system. So my work has not been extended to, children who are experiencing sexual rape trauma, and including those who are child-headed families. And the reason for child-headed families is because we want to strengthen the capacity of families to be able to take care of children. So we want to keep them within the extended family system, but I totally understand there are situations where, their families, their children who are, their own caregivers, so their child-headed household. So my work has not been extended to that group of vulnerable children. And also the second question from Jackson, what could be some of the non-stigmatizing language adopted? So when you are going to intervene or adapt an intervention, you cannot do it, by yourself. So you have to engage the stakeholders, right? Including the group, so youth or children who are going to benefit from these interventions. So you have to adapt or co-create these interventions together such that the language you're using is acceptable, and you agree on what should be in these manuals, or depending on the intervention. So that's what we have done in Masaka. For the family strengthening intervention, we brought stakeholders on the table, including teachers and caregivers and mental health experts in the region, to be able to adapt those interventions to the curriculum, because our interventions are curriculum based, to make sure that the language we're using is actually applicable, but also we adapted age appropriate illustrations and pictures to be able that they meet, to make sure that they meet the needs of the children and adolescents we are working with. So the first step will be to work with stakeholders. Thank you so much.
All right, thank you. Probably you've touched a little bit on the next question, Proskovia. Jackson is asking about what could be some of the non-stigmatizing language adopted from the different geographical scope, if possible. This may help us tailor fit our programs better too.
Yeah. So yeah, yes, that was my last response to that question.
Okay, wonderful, wonderful. Okay, thank you so much, participants. Okay, is there another question that we are missing? I see three here. Okay. I think Andrew is saying, Dr. Richard, my question was mainly referring to how social support can reach the schools and communities as a prevention of decisions made by these children due to the challenges they face. Okay, Andrew, we appreciate that clarity of something more you wanted. Andrew, would you like Dr. Richard to respond more to your queries?
Yes, no? I think the moderator, I think I can respond to Andrew. Thank you for the clarification of the question. And Andrew is saying is referring to how social support can reach them in schools and communities as a prevention of decisions made by these children. It is really important to note that as a result of their such unfortunate background, they make such decisions. And it's not uncommon that we find such decisions many times affecting communities and society where such children live. In Kampala, Uganda, for instance, we've heard of groups of children coming up and forming in a way very, you would say, counter social, counter legal or something, such groups that they say Kasolo group, Chiface and etc. And then they are building an empire. It is us from the outside who will call that criminal gangs. But as for them, they are making decisions for them to continue to survive. Now, his question is, how can social support reach them, for instance, if they're in schools and communities? And in my response, I remember hinting to needs of such specific groups of people. But if they're in schools, this now makes it easier for any of the service provider to reach such children. We have those who are in rehabilitation centers, like camping is in Uganda, around Kampala here. We have those in some gazetted homes. Then we also have those that are still at large in communities, but these are known. And these pressure studies can establish these children or individuals. Some of them are actually not children, but well affecting children. But if they're in school, through the therapies, through the counselings, I have to remind you that we have also a challenge due to the low resourced environment of very few or lack of school-based psychologists, counselors to support these children. So I think these are some of the ways that these children can be reached, and then those communities of people. I want to thank you. I'm told we are running short of time. Over to you, moderator.
Thank you, Richard. There's another question. I think this question goes to AfriChild. Emmanuel is saying, I'm conducting master's research. My topic is on the experiences of women and children with water access in Karamoja. How can AfriChild be of help to me? I think AfriChild is about to respond. They will let us know. That is a question directly for AfriChild. Probably not so much in what we're focusing on today, but AfriChild will be able to help us with that. We have about 14 minutes, I think, to the end of our time. Is that so? Okay. Do we now? Okay. Okay, yeah, thank you. Claire has actually posted something here for AfriChild. You can actually be able to reach out to AfriChild. Maybe they can answer more of those questions. So kindly, if you'd like, you can reach directly to AfriChild. Okay. If there are no other quick questions, maybe I'll now want to hand over to AfriChild Center to be able to bring this to closure. And we want to thank everybody. Thank you for your participation. Thank you for our panelists for a job well done. We definitely appreciate you. Thank you so much. Please, AfriChild Center, over to you. Thank you so much.
Thank you very much, everyone who attended today. We are very happy to have had you with us this afternoon. We have now come to the end of the webinar, and we hope you can join us next time. Thank you very much.
Thank you all. Bye.